to follow in an emergency. When healthcare workers are guided by a plan when in a crisis situation and have trained for hard decisions to be made, those decisions are not made on an ad hoc basis when passions are running high, temperatures are running high, and everyone is already stressed. Those decisions are made based on training, guidance, and medical expertise that led to the development of those plans over usually years. So once again, from my former colleague, James Hodge, prevention is vital. Advanced planning and preparedness can limit situations requiring shifts to crisis mode. So if you plan for your crisis, maybe you can prevent it by seeing where your weaknesses are. Second, saving lives is the end goal. When circumstances merit crisis standards of care, implementation, allocating scarce healthcare resources focuses on preventing excess morbidity and maximizing lives saved. And because I'm a lawyer, the other reason why they matter is liability. So long as public and private sector responses to crises follow sufficient process and are guided by reliable medical/public health findings, they may be legally validated despite negative impacts for select patients or subpopulations. To be clear, liability protections exist outside of crisis standards of care. And this is an illustration of all the different types of liability coverage that exist or may exist during an emergency. The PrEP Act especially protects covered healthcare workers using covered countermeasures during a declared emergency. These laws protect healthcare workers for acts of negligence. What a crisis standard of care implementation does is change what negligence looks like. Having one nurse for 10 patients might rise to negligence in some conventional contingency care situations, depending on the unit, but would be reasonable under crisis standards of care. And that is the heart of negligence. What would a reasonable healthcare worker do given the same circumstances? So we are changing our definition of circumstances by implementing and shifting from conventional to contingency to crisis standards of care. So now that we have discussed the definitions and the importance, we're going to get down to brass tacks and talk about how these crisis standards of care work. Let's get into the meat of how to plan for and implement a shift into crisis standards of care. So emergency declarations and crisis standards of care plans differ across jurisdictions, complicating coordination efforts. Most, if not all of you, work in healthcare, so you understand that. And you also understand that those coordination efforts are pretty constant during a declared public health emergency, which does allow for hopefully improved coordination. One of the complicating factors here is because of the way the Constitution works, there is no federal crisis standard of care plan. The federal government does weigh in on state plans, but there is no true federal plan. And most states have developed their own. Indian Health Service also has their own as well. So those state plans often refer to healthcare facilities implementing their own plans. So we just have layers upon layers upon layers of crisis standards of care plans. For example, the Idaho Declaration in January of 2022 says crisis standard of care are activated in public health districts 3, 4, and 5. Healthcare entities may implement CSC as needed and in accordance with their own CSC policies. So hopefully all of the healthcare facilities in public health districts 3, 4, and 5 were already planning for this, right? They already had a CSC plan in their emergency operations plans. They had their concept of operations laid out, and they had planned and trained, because otherwise the Omicron surge would have been kind of a surprise at that point, I guess. So what your state does is going to vary by jurisdiction. As we know, tribes are sovereign. So how your tribe interacts with a state's CSC guidance will depend on your treaty, constitution, statutes, health code, any intergovernment agreements, as well as mutual aid agreement. Every jurisdiction is going to do this differently. In my state of Delaware, where I am a barred attorney, our CSC plan gave some guidelines for how our facilities should develop their own plan, but the only requirement is that they let the state know when those facilities were going to move into crisis standards of care. That was the only requirement. The state did not have to give them permission. The state did not have to pre-approve a shift into CSC. The healthcare facility just had to let the Division of Public Health know that they were going to shift into crisis standard of care, which they did. Other states did it much differently. So everything is really going to be jurisdiction dependent on this one. So developing a CSC plan, what to do, make it useful in practice, what not to do, make it discriminatory. I will tell you, it is difficult to do both of these things at the same time. No one intends to discriminate, or at least we assume very few intend to discriminate. But when you are making a strategy as to what value to give a life and who to prioritize for life-saving medical care, there can be disparate impact on populations. And COVID, as we saw in past pandemics, was disproportionately more deadly for certain populations, including American Indian and Alaskan Natives anyway. Fortunately, not in the actual fortunately way, we have now experienced from COVID and guidance from the federal government on what these plans should look like. Health and Human Services Office of Civil Rights has weighed in on dozens of state, local, and even the IHS plan to say, this is good, this is not good, you can't use this language, you should not use this language, consider this language instead. So there's a lot of guidance out there on how these plans should work and how they could work. There's also a lot of research coming out on how these plans actually worked in practice. Just a couple of those headlines: inequity in crisis standards of care, non-discrimination in crisis standards of care, just a lot coming out as we make our way out of the public health emergency and potentially into the next surge. So in crafting your plan for crisis standards of care, don't make allocation decisions based on disability, age, race, or sex. Alabama got into a bit of hot water with the federal government. This is straight from HHS website. The 2010 Alabama criteria allegedly allowed for denying ventilator service to individuals based on the presence of intellectual disabilities, including profound mental retardation and moderate to severe dementia. So, like I said, there is plenty of information and guidance from the federal government on what not to do here. IHS's plan was also flagged by OCR and sent back for revision. And following that flag and revision, OCR did post some technical assistance for locations developing their own plan, which is very helpful. So, more legally prohibited allocation biases: race, color, ethnicity, sex, gender, age, veteran status, marital status, religion, exercise of conscience, limited English proficiency, long-term mortality or life expectancy, assumptions of perceived health status, disability, physical or mental, quality of life, individuals' relative worth, inequitable clinical assessment scores, resource intensity due to disability or age, duration of need due to disability or age, advanced planning or steering decisions, categorical exclusions, blanket applications, and stereotypes. So what are we seeing here? If these are all prohibited allocation bases, what are the preferred allocation bases? Individualized patient assessments, specific resource limitations or suitability, objective medical evidence, equitable clinical assessment scores, short-term survival is the big one. Patient surrogate consent and choices. An interesting one is healthcare worker status. This is not a legally prohibited allocation basis. If you have two individuals who are the same on paper and both need a ventilator and one is a healthcare worker, the facility can decide to give the ventilator to the healthcare worker on their status as a healthcare worker alone. And remember the reasoning behind these crisis standards of care, right? We want to save the most amount of lives. And if we're saving healthcare workers, later down the road, we can save the most number of lives, hopefully. An interesting route that some CSC plans take is also building in appeals, especially for government hospitals. Any decision not to provide life-saving care might have constitutional implications, and allowing an appeal is really giving due process to that patient. So saying, sorry person, healthcare worker beat you out on this round, you can file an appeal. We will take another look, or you're going back in the pile for tomorrow. Those types of bases. So this is the state plan that I worked on. And remember that this is not a health facility plan. This was a state plan. This is Delaware's plan. And please note this language of attempts to predict long-term prognosis, especially for persons with disabilities, can lead to erroneous, inconsistent, and subjective decision-making in violation of federal anti-discrimination law. Wow, it's really like the doctors let their lawyer get their hands on this one, which they did, and the lawyer was me. So it was pretty long, and you'll see this is the second page. And we have here, triage tools should not be used to exclude or differentiate among treatment allocation groups. Scores should be used to compare prognoses among patients requiring critical care, triage and treatment decision framework priority considerations. And number one is, for example, SOFA or PRISM scores is appropriate. This was drafted in March of 2020. Recently, a JAMA article came out that showed the disparate impact of using SOFA scores in crisis standards of care, demonstrating that Black Americans were more likely to suffer and not be given the life-saving treatment they needed because they had worse SOFA scores because of chronic conditions, rather than anything that really should have been factored into this allocation decision. So we learn and we adapt and we change. So now that we have our plan, how does it work? When do we put this plan into practice? Your trigger is going to be when you have a sustained scarcity of resources and a patient surge in emergency. And determining your trigger for your facility, for your jurisdiction, needs to be part of the plan. And there are really good examples out there. This is Idaho's example, and it's a good demonstration of the indicators they use to shift from conventional to contingency to crisis, right? So in conventional, one or more counties or public health districts at or near capacity, very typical. Patient transfers temporarily affected, typical. Shifting into contingency, local jurisdictions initiate resource requests, medical countermeasure availability declining, one or more hospitals on diversion or damaged, and patient transfer across all or parts of state is limited. And I'm sure a lot of us can recall times during COVID-19 when there were long periods of contingency. And then shifting into crisis, one or more counties or healthcare entities is experiencing crisis level shortages of space, staff, or supplies, those 3 S's again. Medical countermeasures are depleted, patient transfer insufficient or impossible statewide. Local jurisdiction resources requests unfillable or undeliverable, and multiple healthcare access points are impacted. And this is Minnesota's, and it has very interesting measurable triggers. So unable to answer all EMS calls, more than 12 hours of wait time for ED visits, unable to maintain staffing in ICU, less than 5% of hospital beds available or no beds available. So having these triggers spelled out and in a measurable way inside your plan will make it easier to know when that shift is occurring. So what I learned from working on Delaware's crisis standards of care plan, it's difficult to make something useful that makes everyone happy, right? Ideally, a healthcare worker would want a document that says, choose patient A over patient B. But that is never going to work, right? Everything needs to be an individualized assessment of each patient. And you can't just have an algorithm that spits out who should get the vent and who doesn't. And we have to, what I would recommend doing is look at what jurisdictions or facilities that you admire and agree with on, a social, political, active level are doing. I borrowed a lot from Massachusetts because they rarely get in trouble for discriminatory practices. I could not remember a time that Massachusetts had been dinged by the Office of Civil Rights for something like this. So I said, I'm going to look at Massachusetts. I also know that they have a lot of really great public health lawyers, and I knew that they would have put a lot of thought into this. So talk to your peers, think about, what everyone else is doing and borrow from those documents. If I had included the footnotes in the little excerpt that I included from Delaware's plan, it would have quoted directly to Massachusetts' plan. And third is involve and listen to your community. We had multiple open meetings with disability advocates, members of minority communities to go through the crisis standard of care and receive feedback. We received written feedback from community legal aid, from their disabilities law program, and really got their involvement and their feedback on what we were coming up with to make sure it was something that they were comfortable with and that they believed would support their community and their members. So it may have been a little bit less useful for providers sometimes, but it was legal, and overall the community was happier with it. What I would also say is work with a lawyer if you have access to one. And if you do not have access to one, copy and paste from states that you like and drop a footnote. That's some free non-legal advice. We call that technical assistance, I guess. So how does it work in practice, right? There may be a time when your jurisdiction, your facility is going to have one ventilator and all of these people might need it. And that is why the CSC plan is developed. There's going to be hard decisions, but planning and training will make putting the plan into practice easier. and it will take personal feelings out of those decisions as much as possible, allowing those difficult decisions to be maybe a little bit easier for your staff to deal with. So in CSC planning, they talk a lot about tiebreakers between two equal patients, who gets it. And a lot of plans do this completely differently, right? If one person is pregnant, they get it. If one person's a minor, if one person was previously on a vent, if one person came in with the vent, they get to keep it. The first person who came into the ED gets it. We're going to pull numbers out of a hat. We're going to pick SOFA score. We're going to pick where they are in the life cycle. SVI score. Make the plan for your facility and your jurisdiction what you think it should be and what your community values. There is a study out of the state of Maryland that certain populations value certain tiebreakers more than others. Some believe that those in greatest need should be given priority, while others believe that those with the greatest chance of survival should be given priority. So really understanding what your community values is important to determining those allocation bases. And just a few tribal specific considerations. As I mentioned, there's going to be jurisdiction specific considerations here. What is the tribe's relationship with state, local health departments? Is there an intergovernmental agreement? Is there a jurisdictional agreement? Are you going to be subject to the state CSC plan if there is one? Are there mutual aid agreements in place? What is the tribe's access to the strategic national stockpile? Does that come through the state? Does it come directly through IHS? All of those things are something to keep in mind when developing this plan. Anti-discrimination laws, not likely to be subject to federal oversight for your CSC plan, but must be consistent with tribal legal documents. And formulating your CSC plan, really keep in mind cultural priorities. And like I noted, work with a lawyer if you can. And that's it for my presentation. I'm happy to take questions. I also do have a list of resources. And for those of you not familiar with the Network for Public Health Law, we are a nonprofit sponsored by the Robert Wood Johnson Foundation, and we provide expert legal technical assistance. So if you ever have questions that you don't want to ask now or that pop up later, you can feel free to reach out to us at any time. And on my resource page, I also have a list of all of our crisis standard of care documents as well. But happy to take any questions that you may have.
So as you all start putting questions in the chat box, I would kick it off with some of the questions that you all put into your registration forms. So the first question we have, Joanna, it is, how do we, I'm reading directly the question, how do we overcome the barrier of a health crisis due to limited resources in tribal communities? So in your opinion, what's the first step that healthcare systems you may recommend?
Ooh, let me take a sip. I think coordinating with partners would be my suggestion, right? Especially coming off of COVID, trying to improve the resources that tribe may have, right? So a lot of money was poured into public health for a very short period of time. Now that is being clawed back, but coordinating with local, state, federal resources to try to get as much as you can and try to build up your resources case and in preparation for, when the next public health emergency does strike.
And can you tell me if the Network for Public Health Law has any assessments available that can help health systems like evaluate their preparedness for a crisis or emergency?
Look and see if we do. I will get back to you. If we do not, I can give some recommendations on organizations that do.
Okay. Do anyone online have any questions? Let me look and see. See any hands up? So let me ask this question, and you can use your reactions. How many people during this meeting, you can just raise your hand or put in the chat and say, we do, yes. How many people have crisis standards of care trainings within your facility now since COVID? Yeah, I see some thumbs up, some hand raised, okay. Okay. And then those same people that have your hands up that's responding, have you also updated your emergency operation plans as well? You just use those reactions, those thumbs, raise those hands. How many of you have also updated your emergency operation plans? Let's see some hand raised. It's okay. Okay. So in terms of crisis standards of care, are there additional resources that you all would need? Like, is there like a particular topic within crisis standards of care that you would like a deeper dive on? Are there any needs within this topic that you all feel that you will want more information on? And you can just put that in the chat box. And so, Joanna, the question that I have for you is, I know you work with a lot of states, and it's not unfamiliar territory because you just talked about some of the cases that went federal, had to take it to the court, such as Alabama. And my question for you is, how would a sovereign nation go about working with you all if they had any questions?
Sure. So, yep, here we go. There we go. This is a nice little link here. And that is my email.
Okay. Very timely.
There we go. It's almost like I prepared for that exact question. And like Dree said, this will all be in the PDF as well.
And so a future topic that was, thank you, Monte, for sharing, is CSC for tribal EMS.
I did see, it wasn't tribal, but I did see a resource on CSC for EMS. So I will send that to you, Dree.
Okay. And I will share that resource with you, Monte. I will follow up with you and share that. If you don't mind me emailing you. Let me go ahead and get permission. Okay. So do we have any other questions that we want to ask? Because I don't want to hold you over. But I do want to make sure that in